Hey everybody, this is Jim from the Pain PT, and I had the pleasure to interview Dr. Dave Clarke from the Psychophysiologic Disorder Association, which is now has changed names to the Association for the Treatment of Neuroplastic Symptoms. And I had the pleasure of speaking with him recently, which you're going to hear about in just a moment. I wanted to introduce you to Dr. David Clarke. He is the president of the PPTA, which is now known as the ATNS. The name has changed. We'll talk about this today. It's a nonprofit organization dedicated to ending the chronic pain epidemic. And Dr. Clarke, many of you may know him or don't know him. He graduated from Williams College with a bachelor's degree in psychology. He holds an MD from the University of Connecticut School of Medicine. He's board certified in internal medicine and gastroenterology. His organization's mission is to advance the awareness, diagnosis, and treatment of neuroplastic symptoms. ATNS supports an evidence-based biopsychosocial approach that is safer, more affordable, and more effective than traditional treatments for chronic pain. With a focus on uncovering stress and identifying trauma, the ATNS encourages patients to take control of their symptoms without drugs, surgery, or expensive treatments. A lot of the same stuff we talk about here. Dr. Clarke is an organization's president, renowned gastroenterologist, author of 3 books, producer of 3 films, and an international lecturer on neuroplastic symptoms. So I welcome him here today and look forward to this conversation that you guys can hear. And again, if you enjoy it, give it a thumbs up. We're really trying to spread the word about this work. And so people worldwide can start to learn more about this. The organization's new name again is the Association for the Treatment of Neuroplastic Symptoms, ATNS. It used to be known as the Psychophysiologic Disorder Association. And the mission of this nonprofit is really to share the latest scientific evidence about successful diagnosis and treatment for neuroplastic symptoms. Again, these symptoms are generated by the brain, linked to past or present stress, and include a chronic primary pain in any location in the body, such as migraine, fibromyalgia, irritable bowel, bladder spasm, fatigue, post-viral syndromes, and many more. Millions are affected, but by sharing the pain relief psychology that we use with great benefit in the latest research trials, we can empower patients and practitioners with knowledge that becomes healing. So welcome to the conversation today. Hi, everybody. This is Jim from the Pain PT. Good to see you guys today. I have a very special guest today, Dr. David Clarke here on the line. I'm so happy he's willing to come on today. We just came off a beautiful and amazing PPTA conference in Boulder, and we're going to talk a bit about that and a bunch of other things. So I'm really happy to have you here.
Great to be with you, Jim. It's going to be fun.
It's going to be fun. Yeah. So yeah, why don't we just jump in and maybe tell the audience a little bit about yourself? Some of the audience might not know you. They know your name. I think they've seen your name out there attached to this type of mind-body work or world. Maybe tell the audience a little bit about yourself.
Yeah, well, I'm a double board certified internal medicine and gastroenterology physician, and have been for decades. Became president of the now Association for Treatment of Neuroplastic Symptoms. We've changed our name since 2011 when we were founded. And our mission is to educate the public and healthcare professionals about pain and illness that is not due to injury or disease. And I got into this very unexpectedly. I mean, I was heading for a perfectly ordinary career as a gastrointestinal specialist. But in the 8th year of of my training, my formal education, ran into a patient that was the last thing I expected was to meet a patient I didn't know the first thing about diagnosing or treating. And, she had really severe symptom of averaging 1 bowel movement per month, despite taking 4 different laxatives at double the usual doses. And nobody could find anything wrong with her, including us. I mean, she came to us from another university, and I was at UCLA at the time, and we did specialized testing, and we couldn't find anything wrong. And I was doing her exit interview and basically stumbled on the fact that she'd been severely abused as a girl. And this had all stopped 25 years in the past. I had no idea at the time if such a thing could possibly be connected to physical illness. But there was a psychiatrist there named Harriet Kaplan that I knew was interested in these mind to body connections. And I thought, well, maybe, this patient can live with her symptoms a little better if she talks to a psychiatrist. So I made the appointment and forgot all about her and went on about my business, taking care of organs and structures, until I ran into Harriet a few months later. And this was the elevator ride that changed my career, because Harriet told me she had cured this patient with a couple of months of counseling. And that just blew my mind. Nothing in my 7.5 years of formal education at that point even hinted that such a thing was possible. And I wanted to be a complete doctor, so I prevailed on Harriet to teach me her framework, let me know, how she thought about cases like this, so I would have some basis for helping people, thinking, maybe I'm going to see 2 or 3 patients a year with this problem, and I should know what to do if I want to be a complete doctor. Well, when I got into private practice, 2 things happened. Number one, it was 5 or 6 patients every week. I would do the diagnostic tests and nothing would show up. And I would use Harriet's approach. And lo and behold, I'm finding all of these psychosocial stresses going on in people's lives that were impacting their bodies in sometimes severe ways. And number two, there were no Harriets in Portland, Oregon, where I was in practice. So I ended up having to try to treat these patients myself. And it probably took me 5 years to reach a decent level on my learning curve. So I'm fond of long-winded answers, but that's how I got into this.
Yeah.
And today we're 7,000 plus patients later.
Yeah, amazing. And I'm just curious, that 5 years where you kind of figured it out, or you were, got more immersed in it, was a lot of self-study? Because back then, give the audience a perspective. What years was this that you were
This was the 1980s. Yeah, this was
80s?
a
Yeah.
long time ago, and there were no books on this as far as I knew. I mean, Healing Back Pain by John Sarno was out there, but I'd never heard of it. And if I'd seen it, I would have thought, well, it's back pain. It's got nothing to do with me, because I'm a gastrointestinal specialist. My patients had everything from lumps in their throat to rectal spasm and everything in between. So the way I learned it was I started with Harriet's framework, which was kind of bare bones, but it gave me an orientation. And the rest was listening very carefully to what people were telling me. And even then, I mean, for probably the first 3 years, which would be, 1,000 patients or more, I was missing the powerful emotions that were below the surface, that were repressed, that the patients were not consciously aware of and therefore could not put into words. That very first patient was a good example, the one with the 1 bowel movement per month. Her father had molested her hundreds of times, but she is telling me this in the same tone of voice you'd use to read a grocery list. You could not tell that there was any emotion behind that at all, and yet there were enormous emotions behind that. Tremendous amounts of anger and grief and shame and rage and fear, and it was all beneath the surface, and it was manifesting in her body. But it took me, lots and lots of interviews to begin to piece that together, and then even longer to be able to help people to see and feel these emotions for themselves and be able to put them into words. I'm sure if somebody had done videos of me back in those days and forced me to watch them today, I mean, I'd be beating my head against the wall in embarrassment at all the things that I was missing in those days. But they're just, as a physician, it's kind of embarrassing to admit there was no training for
Yeah,
this.
right. You were light years ahead of all your contemporaries. And I think of you as being the West Coast Dr. Sarno that people don't know about, because you were working in isolation and Dr. Sarno was working in New York. And you had told me privately, and you maybe share the story how you didn't even know of Dr. Sarno, yet here you were on the West Coast doing your gastroenterology. You wrote a book that can't find anything wrong, right? Maybe share a bit of that story, which I find quite amusing.
Yeah, I eventually got to the point where I felt like I had something to share about what I had learned, and that there were all these patients I was seeing personally, and there must be, and we now know there are millions, tens of millions in the United States alone that have these same conditions. So I thought, I need to leverage what I've learned from my patients and put it out there for others to see. And I ended up going on a nationwide tour to explain to people what was in the book and why they might be interested in it. And I did television and radio and lectures, and both for the public and for professionals. So I'm in a bookstore in Chicago, and there's 40 or 50 people there, and I'm giving a 20-minute introduction to the subject, and somebody in the back raises their hand and says, "You sound like Dr. Sarno." And I didn't want to look too ignorant, so I said, "What do you mean by that?" And he explained that there were a lot of parallels in the ideas that we had, and Dr. Sarno and I had both found our way through um, experiencing with patients and listening to patients that emotions and traumas and stress could manifest themselves in the body. In his practice as a physiatrist, it was in people's backs. In mine, it was in the GI tract. But as we know now, it can be anywhere in the body, literally from head to toe, and in more than one place at a time. So as soon as I got back home, I immediately ordered the mind body prescription and read through that. And I thought, wow, here's somebody who has found their way to these same ideas. And a couple of years later, I got an invitation from Howard Schubiner to come to a conference in Michigan where he was gathering everybody he could find that had also reached these same conclusions. And there
Was
were
that
about
2009? Did you guys?
2009. Yeah, it was March of 2009. And, people stood up and talked for about 20, 30 minutes each about what they had learned. And, we're all finishing each other's sentences, and it was such a diverse group. There were physical therapists there, orthopedic surgeon, gastroenterologist, internal medicine, all kinds of people from all over the US and from Europe who were reaching these same conclusions. It was a bit like, having people who were sports fans of different teams around the country suddenly realizing, hey, wait a minute, we all need to be Oakland Raiders fans or something. I guess they don't even exist anymore, but we
Yeah.
had all converged on very, very similar concepts just from careful listening to patients. It was truly a revelatory experience for all of us, I think, to see that we were not alone.
Yeah. Because you have been working in isolation, basically.
Completely.
Yeah. Which I think a lot of practitioners have been, and we'll get to the more recent conference, but leading on from that, so then you just practice for the rest of your career with an eye towards these type of patients. And did you start seeing people come to you then after hearing that you did more of this work? Did you have people coming to you like Dr. Sarno did?
Oh, yes. I mean, that was even earlier than that. I mean, once I reached a decent level on my learning curve back in the 80s, I worked for a very large HMO in Portland and um, received the Doctor of the Year award from them. And the citation for it was all about helping patients with these seemingly intractable, impossible conditions. And people took note of that. And whenever they had somebody that made no medical sense, they started sending them over to me. So I was getting patients with back pain, patients with itching of the skin, patients with pelvic pain that the gynecologist couldn't figure out. All of these different kinds of cases started coming, and
Hmm.
by using the same ideas, we were having success. I was having success alleviating those symptoms.
Yeah, that's
Even
great.
even in people that were not, formally in my specialty. So by the time I got to writing the book, there were so many invitations after that came out to give lectures both to the public and to professionals. I just closed my practice in 2009 and began teaching, became a teaching doctor basically.
That's amazing. That's great. You were getting awards, and Dr. Sarno, Dr. Schubiner were being shown out the door and not getting quite favorable treatment. So that was great. They were open to it and saw the work that you were doing. So you
Yeah,
transitioned. So you transitioned from treating patients into becoming like a teacher, like you said. Maybe share with the audience what happened after that, because you started the Psychophysiologic Disorder Association, and I was surprised to hear how long it's been around. I didn't realize that. Maybe share a bit about that when you started that organization.
yeah, it was such a peak professional experience, that conference that Dr. Schubiner and Dr. Strax put together in 2009. And a number of us felt we just had to start a nonprofit to get the word out there so that there could be more than just 30 of us that were doing this work. It took a couple of years. I mean, we had to fundraise, we had to create a website, we had to choose a name, and Psychophysiologic was our initial name, a blend of psychology and physiology that we hoped would educate healthcare professionals about what was going on. And we launched, we got I did all the legal work myself and filed with the IRS, and we got our 501c3 nonprofit status and launched in the spring of 2011. And I've been the president since then. We've had a wonderful board of directors. All of us are volunteers, myself included. And we've had, some turnover on the board, but, there's been a core group that have stayed with us the whole time. And we've gradually grown and expanded and been able to do more and more. One of our biggest accomplishments was raising money for the Boulder back pain study. We were told that they were willing to study the psychophysiologic or now neuroplastic approach to chronic back pain if we were willing to fund it. And so Howard Schubiner and Alan Gordon put together a wonderful 2-minute promotional video, and the PPD Association, now the Association for Treatment of Neuroplastic Symptoms, or ATNS, I'll call it from now on. We put out a way to receive the money, and we raised over $100,000 from over 500 donors from 24 countries, which enabled the University of Colorado at Boulder to conduct their back pain study. And it was dramatically successful. The patients who had an average of 10 years of chronic back pain, their pain scores dropped from an average of 4 down to an average of 1 after just 1 month of treatment. 10 years of pain, and it dropped like a stone after just the 8 1-hour sessions of pain reprocessing therapy. Just an astounding result. The lead researchers were shocked at the statistics they were seeing from this. And that, was huge because it opened the door to more funding for more studies. People who were researchers, they could point to that study, the Boulder back pain study, and say, look at this. We need to investigate further. We need to replicate this. We need to find out what's going on. And people with money, institutions with money, were now willing to pay for this where they hadn't been before. So that was a tremendous catalyst. We've also helped support 3 documentary films in the field. We've written 2 textbooks. We've got a really solid 500 plus membership base. It's, the influence of the organization has just exploded in recent years.
Yeah, just pretty amazing to see. And, we were at the last conference in Boulder, Colorado, I'm still buzzing from it, Dave. I'm still coming down from the conference.
Yeah, you and me both, Jim. We had virtual conferences. We had a live one in 2012 in New York. It was a huge amount of work, and nobody was anxious to do one like it again anytime soon after that. But as we grew, we had a virtual conference in 2021, another one in 2023, and then this year we decided, okay, we're going to go for it. We finally had raised enough funds to have enough staff that we could actually do the work, which is huge, to put on a live conference. And then, of course, the question is, if we build it, will they come? And we didn't know, but it exceeded expectations. Our wildest dream was to get 250 people to come. We got 268.
Hmm.
And just the joy in that room was over the top. I have never seen anything like it. There was more joy at that conference than in all the other conferences I have ever been to combined.
I
And
agree.
I
And my,
I
my
have been
cup
to
was
a lot of
overflowing.
conferences.
I know my
Yeah.
cup was overflowing. It was just truly incredible to see, like you said earlier, the 2009 conference, people coming together. There were more people coming together from all sorts of disciplines and recovered patients and coaches. And just to see everybody uniting in the same direction is just beautiful to see. And maybe share a bit about the name change, because I think that's significant. Why, a bit about that. Why the name change?
Yeah, absolutely. And before I forget, I should say, in addition to joy, the quality of the scientific presentations was, uniformly remarkable. I mean, Dr. Kennedy on our board um, gathered all the speakers, and they all came and spoke for free. We didn't have to pay them. They were willing to come and share their ideas and experience at no charge for us, which was, huge for us. And the quality of their presentations was just uniformly remarkable. Other conferences I go to, it can be up and down,
Yeah.
but the people that Becca Kennedy gathered were just wonderful. So we have also been talking all year long about changing our name. It's clear that going forward, we need to be communicating with the public more, trying to educate people that neuroplastic symptoms exist. Neuroplastic is a word that obviously combines neuro for nerve, also brain, and plastic in a medical jargon means capable of change. And we think that's a really positive message for people that are suffering with the pain or illness from this condition. So we like that word. And we wanted to replace psychophysiologic because, even though psycho means psychology and not psychotic, people were confusing it. They didn't like the psycho part. And we came to understand that it was probably hurting our ability to communicate with the public in particular. So we are going with, after very long debate, which involved lots of outside experts in communicating with the public, including Nathaniel Frank, our newest board member, who's a journalist. We settled on Association for Treatment of Neuroplastic Symptoms.
Yeah.
And the last word, the symptoms word, is important too, because it's not something that's inherent to you as a person. It's just a symptom. And that means also that it can be changed.
Yeah, absolutely. I love the new name. I think it's perfect because neuro, like you said, brain, nervous system, plastic, we can change it. Even the word symptom is better than disorder, I think, too. It's a little bit milder word. So I really like the new name. I know there's a lot of discussion about it, so I think you chose the right name.
Thank you. Yeah, there was a lot of discussion, and I was trying to lead us out of that wilderness for the longest time, and it really took those outside experts to reframe our thinking.
Yeah, so maybe tell the audience a little bit about what are you doing now with the organization, because you've been working behind the scenes. I think you're not out there as much, as some of the more practicing doctors and MDs that are working. So you're working behind the scenes more. So maybe let the audience know what you've been doing.
Yeah, I'm starting to come out from behind the scenes. I've been working with a public relations firm for the last year to reach the public. They send ideas that I have about different ways to communicate around this out to 2,500 healthcare journalists every month. And those journalists then write about us. They invite us to be on podcasts. They invite us to be sometimes on television broadcasts and radio. So we're having an opportunity to reach the public with this new idea for the first time about the brain is capable of causing pain or illness in your body every bit as severe as any other form of illness, and yet effective treatment is available. So it's a very positive message, and that's going very well. I mean, in just as one example, in February of this year, I was on a radio program for 2 straight hours that has an average listenership of 1.3 million people. It's just really hard to reach that many people without coming onto mass media and being able to share your message. So that was huge for us. We got I think a tenfold increase in the number of website visits in the days after that broadcast was done. We're working on supporting more research. We're growing our membership. We're going to be launching a brand new website. We're probably going to be having a regular podcast next year where we'll do interviews like this one with professionals, but also with patients. I'm hoping to bring some patients on and have not so much a therapy session with them, but more of an educational session, both for them and for anybody who's watching it, to show the approach that I take and all the ideas behind it, so that that's not only going to educate patients who are watching, but also the professionals about, in particular, some of the concepts that patients themselves find difficult to put into words. I think for so many, a neuroplastic condition is about the bodily expression of emotions and stresses and traumas, and that often the reason they're being expressed via the body is that the person doesn't know how to put them into words or isn't even consciously aware of them.
Mhm.
So figuring out what's going on in a person like that is a challenge that I've been facing for 40 years. And I think I've got some ideas that I can share that other people can learn from.
Yeah, maybe if you don't mind, share a few of those ideas you've learned over the years, because I think that's super important for the audience. I get mostly people, clients and patients and people suffering that are listening. So I'm sure they're wondering, what does Dave have to say about this?
Yeah, absolutely. Well, the people who are the most ill with this, the people where it goes on for the longest period of time, uh, usually it can be traced back to adverse childhood experiences. Something that happened to the person as a kid, either as a single event or as a series of ongoing events through the years, that was traumatizing for them, or was really anything that you wouldn't want to happen to a child of your own. And that's an important way to frame it, because many people who look back, they don't see it as all that bad. None of us has a parallel life to compare ourselves with, so we really can't judge just how much adversity we had to endure for ourselves. But if we think about the same things happening to a child of our own, or any child that we care about, that puts a completely different spin on it. And it's an exercise that often helps people get a much more accurate sense of what they went through. And it also helps connect them with some of the emotions around that. That if, for example, they were forced to watch a child of their own go through everything they did as a kid, how would they feel about that? Would there be some emotions that start to come up? And if there are, those are very likely exactly the emotions that are being expressed via their bodies and creating symptoms. And we can start talking about those, and people can start journaling about them. Or another exercise that I have people do is write a letter to someone who mistreated them as a kid, not to mail it, just to write it. And very often, the more they can put those emotions on a piece of paper or on a computer screen, the less they need to go into somebody's body. Um, the other major long-term impacts that I look for are personality traits that are stressful for people, that they developed when they were kids trying to cope with an adverse environment. Triggers which are people, events, or situations in the present day that are highly stressful for people because they are in some way linked to the stresses of the past. And then finally, those emotions that I talked about earlier, anger, fear, shame, grief, guilt, that developed when a person was a kid, and that are buried and that people are not consciously aware of, and using techniques for trying to help people develop their conscious awareness of those emotions so that they can be expressed verbally.
Yeah, that's great. Do you find in your career over working with a lot of people, certain emotions more than others that you find that were more likely to be repressed, or do you think it's across the board, just a variety of emotions?
Yeah, it can be across the board. It can be a mix. But often the dominant one in my patients is anger, that something has happened that has made people angry. Something has happened that if it happened to you or to me, that we would be angry about it. But in order to survive the early years, they've had to take that anger and bury it somewhere. And so a lot of my patients resemble dormant volcanoes with boiling magma inside of them that, except in unusual circumstances, you never see the anger. Every once in a while, somebody will be triggered and the anger will burst out, and the person will be wondering, why this anger came out for seemingly minor reason. And it's because it's in there and it's under pressure all the time and doesn't take much to trigger it. The classic example is a road rage incident, that somebody gets cut off on the freeway and they feel disrespected and their anger explodes, and you can get all kinds of crazy things that happen after that. It's not an unusual occurrence in our society, and it's very likely that people that develop those rage reactions, they have been through something as a kid that has left them with that boiling magma inside, and it gets triggered by the road incident.
Right.
In my patients, the anger is there, but instead of being externalized as road rage, it's internalized as a physical symptom.
Yeah, I see a lot of that too. In fact, I had someone just today where somebody I get people who are never angry, and I get some people who used to be angry. Then they started bottling it up because of different life reasons. And then they started experiencing symptoms. Or even shame, like you mentioned. I see a lot of people with shame because of the abuse and neglect and first childhood experience that they've been through. Heavy, heavy shame. Maybe touch on that emotion and what you've seen in your practice about shame.
Yeah, the patient who I am reminded most of in relation to that word was a 22-year-old with irritable bowel syndrome for 5 or 6 years. And this is probably the only time I can remember where a patient said something to me that was so shocking that I didn't know how to respond. I mean, I've talked to so many patients. I can usually find a positive way to react to just about anything, but this particular patient just stopped me cold. And what her experience was that her father molested her on a regular basis. And she was, a clever young lady, and she could sometimes avoid that and, stop him from doing what he wanted to do. But at the age of 9, she noticed that when she succeeded in avoiding him, he would take out his frustration by beating up her twin 5-year-old brothers. And she realized this, and she was so saddened by what her brothers were going through, and she realized why they were going through it, that she decided she was going to stop trying to avoid him. And from then on, she just let him do what he was going to do. And I just could not believe that a 9-year-old would make a sacrifice like that. I just did not know what to say. And while I was sitting there frozen, staring at the wall, not knowing how to respond, the next thing she says to me is, "I felt so ashamed."
Mhm.
And here, she had made this incredible sacrifice to save her brothers at the age of 9. And what is the outcome of that? It's not that, I was brave, that, I was courageous, that I was, making an incredible moral decision as a 9-year-old. It's that she felt ashamed.
Hmm.
And the reason she was in my office as a 22-year-old was that the burden of that shame had been creating irritable bowel syndrome for the previous 6 years.
Hmm.
So, eventually I got myself together and I was able to help her, but damn,
Yeah, there's
that
some
that was a hard one.
yeah, there's some incredible stories that we hear, and I mean, I hear them as well. And the more your ears are open and you're listening and right asking simple questions, you hear a lot. And I'm always amazed too, and you probably as well, with just very simple questions, right? Asking the patient very simple questions, you can get a lot of information that you wouldn't normally get by just your medical questions. So,
Yeah, and being willing to hear it, I mean, you
mm,
you got to hear some really hard stuff, and you have to be accepting of it. If the patient senses that you want to run out of the room, they're not going to be as willing to disclose. You have to be um, very willing to hear these things and to feed back to the patient that these experiences have happened to many people.
yeah. Maybe talk a little bit about, since we're talking about emotions. I know there's a lot written about journaling, and that's one strategy and avenue, like you mentioned, that patients can use to express emotion. There's also more recent emotional awareness and expression therapy, which was really nicely highlighted at the conference. Brandon Yarns and Dr. Schubiner, and maybe talk a little bit about that, because that's sort of an evolution, right, from the work you've done and ISTDP and Dr. Sarno's work, and that has a little bit more research coming out to support it. So maybe share with the audience a bit about that.
Yeah, I personally consider that I've been doing emotional awareness and expression therapy throughout my career. I mean, that's just um, those are the concepts that I came to through years of trial and error with patients. To find what was the most effective in helping people recover from this form of illness. And finding, once I realized just how prevalent these powerful but repressed negative emotions were, I focused a lot of attention on helping people to find these emotions in themselves and then convert them into words, because it's probably the single most powerful technique for alleviating physical symptoms, to find these buried emotions in people and help them put them into words. Pain reprocessing therapy doesn't do that directly, but it does it indirectly by shifting people's attention to what's going on in their brains, shifting it away from what's happening in their bodies, which is naturally where a person who's ill or in pain is focused. And it shifts them to the brain and figuring out, okay, your brain is doing this to you. Why is it doing that? And that question naturally occurs to people, and they start thinking about what might be the stresses, past or present, that are doing this, and they're going to find their own way toward the presence of those emotions. One of the stories that comes to mind in this regard is a patient that I asked to write a letter to his dad, who had mistreated him emotionally and verbally throughout his growing up years, and to put down all the emotions, both good and bad, that he felt about his dad in a letter, not to mail it. Well, his father was deceased, but if his father had been alive, not to mail it, but just to write it. And he ended up taking this letter to his father's grave, where he read it to him out loud. And he said it took him 4 or 5 hours to read the whole thing. And by the end, he was shouting. But tremendous catharsis for him. And his physical symptoms were 90% better after he did that.
Wow. Yeah. The power of that expression is just amazing and sometimes dramatic when you can see it that way. Right.
Yeah. Yeah. That was quite
Yeah.
a story.
Quite a story. Yeah. I think of, from the conference and where the work's going, it seems like we have there's multiple prongs, right? There's the PRT, pain reprocessing therapy, like you mentioned, reducing the fear and being able to understand it's your brain, education, sitting with the sensations, right? and then be able to move to the deeper emotions like the EAET, emotion awareness expression therapy. So I think it's a really nice two-pronged path, right? Working with the fear, then getting into some of the deeper emotions, which I think are the core emotions that we see in a lot of people. And that was mainly your work, I think, was going to some of those core emotions that people had around traumas and PTSD events and traumatic events like that.
Yeah, I look at it, and I know Howard Schubiner looks at it this way as well, is that there's a kind of a layered approach depending on how severe the patient's condition is, how deeply buried the issues are. I mean, as we've all heard, some people can be relieved of these symptoms just by reading a single book. And, thank goodness there are so many excellent evidence-based books out there now. When I started, I don't know if there was anything other than healing back pain, of which I was unaware. Now we've got lots of excellent books, and if one doesn't work for somebody, another one probably will. But if the book doesn't work, then we have apps like Curable. If that's not sufficient, then we've got training programs. There's some on endchronicpain.org, and we're going to be putting a new one on there probably next year. It's going to be more video based. And then if those don't work, there are individual psychotherapists who have taken extra training in this field and who know all about the stresses, the trauma, the emotions, and can help people work with that. And the therapist can start with pain reprocessing therapy. And if that's not sufficient, go to the next level of more directly addressing the emotions and helping people be aware of those. So it's kind of a multi-level approach, and the most sophisticated and challenging treatments are only needed for a fraction of the patients.
Yeah, I think that's important to say that there's a lot. I think some people get confused. The people I talk to, what do I focus on? What do I do? Because there's the understanding piece, like someone can read a book and their beliefs can change and they know they're not in any danger or threat. They're okay. Some people can do PRT, and then some people need the EAT or more deeper psychological work. And what's been your experience with that in your career? Because you've seen a lot of people. Because I'm always trying to bifurcate patients and think, okay, this person might need a bit more. I mean, I always look at the trauma history. I think is important and what adverse childhood experiences the person's been through, right? So maybe talk a little bit about that. I think that's a little bit more in-depth question about looking at the different subsets of patients and what they might need in treatment.
Yeah, in my practice, being a specialist, I tended to get the people who were the most ill, the most confusing diagnostically, and who therefore had the most complex and buried issues. One of my patients had suffered from this condition for 79 years, and nobody, anywhere in her medical record had bothered to ask the question, well, did anything happen to you when all of this started that was in any way traumatic? Because, she was 87 years old, and she'd been having these symptoms since she was age 8. And so, that seems a long way removed from
Yeah.
somebody who's 87, but that was right where I went. Is, tell me what happened when you were 8, around the time that this all began. And sure enough, she gone through a huge trauma. It's kind of a long story to explain what it was, but she had a huge burden of guilt after it, and she carried that with her for all those decades, and had pain more often than not for all that time. She was a nurse, so she had very ready access to medical care, and nowhere along the way did anybody figure out what was going on. And by talking to her about the trauma and using some techniques to help alleviate the burden of guilt, she got better.
Mm.
Even after all those decades. So it's a great story because it shows the power of this illness, but it also shows the power of the brain to create symptoms over such a long period of time.
Yeah.
But it also shows the tremendous potential for relief.
Yeah, that's right. And just, that many years, it shows you a couple of things. Yeah, that trauma doesn't matter how long it's been, it can still be activating in your body. And doesn't matter how old you are, you can still work to remove it or ameliorate it with these practices.
Yeah,
Yeah, the power of emotion.
neuroplasticity. Yeah, neuroplasticity is not the same when you're 87 as it is when you're 18, but there's still neuroplasticity there,
Yeah,
the
yeah,
capacity for change.
that's an amazing story. And I think people just don't realize the impact of traumatic events, right? Adverse childhood experiences and things. Like you said earlier, people just think, "Wow, that was my childhood," and that's just how it was, and it wasn't so bad. And people they don't believe that that could still be operating now, or some event now can open up this wound, and all of a sudden we have this pain. And it's just incredible that emotions can do this. I mean, same thing with my work, being a physical therapist. Opening my eyes, so it's just blowing my mind now of the stories I hear and the symptoms I see. It could be anything in the body. I mean, I'm probably, like you said, the same thing. You see all sorts of symptoms.
Yeah, the only common denominator in the range of symptoms is that there tends to be more than one at a time. And the more symptoms a patient has, and the more diverse they are in their locations and their qualities and intensities, and whether they move around a bit, all of those things increase the odds that you're dealing with a neuroplastic condition. My personal record patient came to me with a printout from the internet on which he had circled 27 different individual symptoms that he personally was suffering from at that moment. Just and he was cured in 30 days. I mean, he was just suffering from depression, and while he was going to be getting some therapy for those issues, started him on an antidepressant medication, and it kicked in the usual month or so, and all 27 symptoms went away.
Wow. It's incredible. It's truly, truly incredible. Yeah, these emotions have such a powerful effect. And what do you think about some of the complex cases where you see, and I'm always curious about them, where you do see findings, and that might even correlate with a symptom in the body. Yet when you get their history, it's a completely psychosocial trigger. I've had a few people like this where I said, well, I can't definitively say it's a neuroplastic symptom, but I find those cases very interesting where it's like there's definitely been some psychological trauma or event, and that's when it started. Yet there's also findings on the MRI and X-ray. Do you have anything to say about that?
Yeah, absolutely. Patients frequently have trouble with this concept. I mean, just as I did the first time I encountered these ideas, can this really be happening? Can your brain actually do this to you? And I was started out somewhat skeptical, and a patient who was just hearing about this for the first time, it's only natural that they're going to be a little skeptical about it, especially if there are abnormalities on their diagnostic tests. And so I just don't try to force somebody to believe one thing or another. I will just tell them, look, we're going to do whatever needs to be done for the physical abnormalities that you have. And we're also going to work on these psychosocial issues at the same time. And as we go forward, we're going to figure out the relative contributions of those things, and it could be that the neuroplastic condition is 20% or 50% or 80% of what's going on. We might not be able to estimate that accurately on day one, but probably on day 30 or day 60, we're going to have a much better idea. One of my patients he's actually a colleague of mine. It was his patient, had ulcerative colitis that flared up, inflammatory condition of the large intestine. The lining gets red and raw and bleeds. And he had a colonoscopy that showed that this was in fact going on. It was giving him terrible diarrhea. And he was given appropriate treatment for this and did not get better. So he was put in the hospital and was given, very aggressive hospital-based treatment in an effort to turn the situation around. Didn't work. So he was scheduled for surgery, which is the last resort treatment, as you surgically remove the entire large intestine as your last resort treatment, which cures the illness, but it's obviously rather drastic. But my colleague noticed or recognized that the man's diarrhea was following a rather odd pattern. It would be pretty bad for 3 or 4 hours a day, and then the rest of the day he'd be okay, which would be unusual for somebody whose bowel was inflamed from stem to stern. So he did another check. He took another look with a colonoscope in there to see what was going on, and was surprised to find that the lining of the man's bowel was now healed. The disease is still there, but all those months of treatment had, for the time being, healed all the mucous membrane, and you could not tell by looking at it that there was, any difference from a normal, healthy colon. So clearly, he did not need to have his large intestine surgically removed, but equally clearly, his diarrhea that was still going on was unexplained. So he asked me to see the patient, and make a long story short, this man had been sodomized by his father multiple times as a boy, and he was having some major psychosocial stress over this. He had been to a therapist, but earlier in the year, but the visit had not gone very well at all, and he was very disappointed and canceled the follow-up appointment, and was in a severe level of distress over this issue and didn't know what to do about it. So we got him connected with a therapist who had experience with these things, and he made very good progress there, and the diarrhea went away. So it was only when both issues were successfully addressed that he got better.
Yeah, interesting. What about food sensitivities? A lot of people have sensitivity to different foods, things like that. Being that's your field, maybe could you touch on that for a moment?
Yeah, it's very common. If you've got stress-related irritable bowel syndrome, or stress-related what's called functional dyspepsia, anything that's a neuroplastic condition affecting the GI tract, it can happen pretty much anytime, anywhere, in relation to stress, either an obvious stress or a hidden one. But it's very common for people who get their gastrointestinal symptoms to immediately think about whatever they just ate. And they will often blame that food for the flare up of their symptoms, and they will then eliminate it from their diet. And I've had patients who come in who are down to white rice and white bread and white flour, and just very, very restrictive, because they've eliminated all these foods one after another every time their symptoms flare up. And for the most part, the majority of people who believe they have a food sensitivity do not. It's actually just their stress-related gastrointestinal symptoms that are causing the symptoms. Now, if you've got a food that causes exactly the same symptoms 10 times out of 10, I'm going to believe it. But short of that, if somebody says, well, 5 times out of 10, I get a reaction to this food, and the other 5 times I don't, that's really not a food sensitivity. It is important to be tested for celiac, because it's so common, and it can really cause significant issues for a person, not just in the bowels, but in many locations in the body. So I absolutely advocate getting appropriate blood tests, and even sometimes a tissue sample, a biopsy of the small intestine to look for that. But, if a person doesn't have celiac, then I'm looking for the psychosocial issues, and I'm going to address those. And once I've done that, the person's symptoms should be improving, and then they can gradually reintroduce the foods that worried them.
Yeah, yeah. And what about even gluten? That's a big buzzword now, and I've read some studies about celiac, having actual gluten sensitivity, but there's been some studies showing high nocebo with gluten as well, with the brain taking the center stage there. So maybe share that a little bit too, because that's a common one now with people with gluten.
Yeah, it's the same principle with any food sensitivity that is actually triggering you because of issues with the brain and the psychosocial stresses, and the nocebo effect, as you point out. And again, what I'm going to do in a situation like that is identify the past and present psychosocial issues, and that includes making sure there's not depression, anxiety, or post-traumatic stress going on, because those can be much more subtle than most people recognize, much more subtle than most medical professionals recognize. And once I've identified those, we're going to try to treat them, which is nearly always successful. And then we can reintroduce some of these foods. Again, making sure that the tests for celiac are negative.
Yeah, great. Well, with just a bit of time left here, maybe just we'll finish on where do you think we're headed? I mean, we had an amazing conference, and I know you covered your past and present, and you're working so hard towards the future. Where do you think we're headed as a in this field?
Where we are headed is greater public recognition and greater professional recognition that the brain can cause pain and illness in the body um, every bit as severe and long lasting as any other form of illness. We need to make recognition of this condition every bit as widely known as diabetes, cancer, and heart disease, because this is afflicting nearly twice as many people in the United States as diabetes does. So it should be at least as widely known. And especially since diabetes doesn't have a cure, it's got a successful treatment, but it doesn't have a cure. And for this condition, we've actually got a cure for many people. We can make these symptoms go away and stay away indefinitely in most people once we identify the underlying cause. So it's completely unconscionable that 50 million people are looking for answers for this when the answer exists. So that's our goal. That's our mission with the PPDA, is that everybody who has this condition, I guess I'm sorry, we're the ATNS now. Everybody who's
Hard to get that out of your head. You've been saying
13
for
years of
too long. Yeah.
yeah, sorry about that. But yeah, the goal for the mission for the ATNS is to ensure that everybody who has this condition, neuroplastic symptoms, gets the treatment they deserve.
Yeah, it's wonderful. And I think we're headed that way. Everybody was really optimistic, and I think it is shifting and changing, and the organization's changing as well, and growing, and more information is getting out there. So yeah, thank you so much for taking your time to come on and share your wisdom, Dr. Clarke. It's just always pleasurable to chat with you. And I'm glad you've been willing to come on and share some great info today.
Thank you, Jim, for all the work you're doing, not only with your patients, but here on this podcast to spread the word. I appreciate it.
Yeah, thanks so much. We'll see you next time. Bye.